Chapter 2 is going to look at cholinergic pharmacology. Our next group of drugs to discuss are muscarinic receptor antagonists, where atropine is the prototype of this class. Atropine is a tertiary amine, as we've discussed previously, which means it's very lipid soluble. It can enter the CNS and obviously also work in the periphery. Atropine is a plant-derived drug. It's referred to as a belladonna alkaloid. Belladonna, that term means beautiful lady. So what made the lady so beautiful? That's because she had big pupils. I suppose centuries ago, if we fed women plants that contained belladonna alkaloids, they got those big eyes, we thought, man, that's a good-looking woman right there. You know, today I would have to tell you if I saw a woman with big eyes, I would think that she's on drugs. She still looks good, by the way, but she's definitely taking drugs. What about Jimson weed? That's also a plant where you can find atropine-like compounds. If you've ever heard of kids eating loco seeds, don't you want some of that? Don't you want some loco seeds? They can carry these seeds around in their pocket. They can eat these seeds. So if you ever want to take a trip without leaving your chair, get some Jimson weed, because you can have some hallucinations. You take a nice little trip after all. When we look at the pharmacologic effects of muscarinic receptor antagonists, they're listed in your book in the order of increasing dose. Now, that's not as important as just remembering these effects overall. In fact, I would encourage you to memorize as little as possible. Memorize as little as possible here. So, we start with decreased secretions. Muscarinic blockers are going to dry you up. That salivary, bronchiolar, and sweating are all going to be decreased. In fact, the patient is going to be hot and dry as a result of this effect of atropine. You get pupil dilation, mydriasis, and you also get cycloplegia, paralysis of accommodation. That means that muscarinic antagonists are good for dilated eye exams, but they're bad for the elderly. Now, why would I say that? Why would they be bad for the elderly as it relates to the properties of these drugs in the eye? Well, earlier we mentioned the drug pilocarpine can be used for glaucoma. Muscarinic agonists, in fact, can increase the drainage of aqueous humor. So what is a muscarinic antagonist going to do? Possibly precipitate glaucoma. So we have to be very careful about using muscarinic antagonists in elderly patients who are automatically going to be more prone to developing glaucoma. You get hyperthermia from muscarinic antagonists. You can't sweat after all. These drugs are blocking sweating, so your temperature is going to increase. In fact, this is what is most often fatal for young kids who get exposed to this type of drug. Temperatures as high as 107 or 108 degrees Fahrenheit have been observed. When your temperature goes up, you're that hot and you can't sweat. The way that the body will try to compensate for that increased temperature is by vasodilation. Your blood vessels try to help. They vasodilate in an attempt to dissipate the heat. That's why you get this flushing reaction with muscarinic blocker overdose. Finally, tachycardia. Block of those M2 receptors on the heart increases the heart rate. But you know, sometimes you could take advantage of things like this. We can take advantage of that property of a muscarinic antagonist to treat a patient with AV block, where they've got slowed conduction through the AV node. Muscarinic antagonists like atropine can increase conduction and can be useful for AV block. Other side effects of muscarinic antagonists include urine retention and constipation. Once again, those are things that you should be able to predict based on the properties of these drugs. But you also get central effects. You can get sedative effects from muscarinic antagonists, but you can also get behavioral excitation and hallucinations. We've mentioned that muscarinic M1 receptors are the primary muscarinic receptor in the CNS. And so you can imagine that blocking those M1 receptors, perhaps that might have a sedative effect. But every nerve that releases acetylcholine has a negative feedback mechanism, and that's mediated commonly by M2 receptors. If I inhibit an M2 receptor, blocking an inhibitory receptor, it's like a double negative. If you inhibit an inhibitory receptor, the pathway can become stimulatory. And perhaps that explains why you can get a sedative effect, but also an excitatory effect from the actions of these drugs on acetylcholine. This slide is going to be very, very important for your Step 1 exam because it lists other classes of drugs with antimuscarinic pharmacology. These are all drugs and all points that we're going to cover in later lectures, but let's summarize them right now. First, we have antihistamines, but specifically focus on first-generation antihistamines. You see, not only does this group of drugs block histamine H1 receptors, but first-generation antihistamines also block muscarinic receptors. What about TCAs? You remember that one of the side effects of a TCA is cardiotoxicity. In fact, we're going to discuss in a later lecture all of the different ways that TCAs can be cardiotoxic, but you should be able to identify one of those ways right here on this slide. TCAs block muscarinic receptors. That's going to increase your heart rate, perhaps leading to arrhythmias. Antipsychotics can also block muscarinic receptors. When we cover that group of drugs, we're going to discuss that those antipsychotics might block as many as 3, 4, or 5 different types of receptors, including, in many cases, they block muscarinic receptors. Quinidine. What an odd drug this is. Quinidine is an antiarrhythmic that causes arrhythmias. When we get to quinidine later on, we're going to do an exercise called Why I Never Want to Use Quinidine. It's very exciting. One of the reasons why quinidine can be pro-arrhythmic is that it blocks muscarinic receptors. It's going to increase the heart rate. Not good if you were trying to use that drug as an antiarrhythmic. Amantadine. It's a drug that we formerly used as an antiviral, but can still use as an anti-Parkinson's drug. Remember, we focus on Parkinson's disease a lot of times by thinking about drugs that increase dopamine. But there's an important component on the other side of that pathway that we need to look at. In Parkinson's patients, we also want to block muscarinic receptors, and amantadine can do that as well. Finally, we have meperidine. It's what I call the oddball of the opioids. It is the opioid that is different from the others. In fact, if I reminded you, opioids cause pinpoint pupils. Opioids cause meiosis as one of their properties. But this one doesn't. Meperidine is different. That's because it blocks muscarinic receptors. In fact, it's more likely to dilate the pupils than to constrict. Again, different compared to the others. My clinical vignette reminds us what are some of the properties that would help you identify you're getting antimuscarinic effects. Let's say you're taking a TCA or an antipsychotic. How do you know that patient is experiencing antimuscarinic effects? Well, they could get mydriasis. They might not complain about that, by the way, because they look really good. Tachycardia, increase in heart rate, that could lead to arrhythmias. That could be a real problem. Look at the next symptom, dry mouth. Folks, don't underestimate that. Dry mouth could be the answer to the question. You think that's kind of nagging, annoying? It is. That is a very, very common complaint. Dry mouth, decreased salivary production. So you think about it. That can lead to dental problems, increased risk of cavities, just poor oral health overall due to decreased saliva production. Finally, urine retention. Maybe you've got a patient who's taking a new antipsychotic. Their schizophrenia is well controlled, but they complain of urine retention. What receptor is associated with that side effect? It's block of muscarinic receptors. Perhaps that patient could benefit from the addition of bethanechol, the muscarinic agonist that will increase both GI and urinary motility. When you get a patient who is overdosed on a muscarinic receptor antagonist, our treatment of choice is physostigmine. As we covered earlier, this is the tertiary amine that is able to get into the CNS and work peripherally to overcome the effects of the muscarinic blocker. Here's our table that looks at the different muscarinic blockers. The 4 letters that you should pay attention to that many of these drugs have in common is trope. The letters T-R-O-P, found in atropine, tropicamide, ipratropium, tiotropium, and benztropine. If I see trope, that's a muscarinic blocker. You'll notice that one drug is a scope, but not a trope. The drug scopolamine starts with SCOP. So maybe there's a way to remember, kind of a catchy way that says tropes and a scope. Those are my muscarinic blockers. Now, none of that, of course, helps you to remember a drug like trihexyphenidyl, which is a terrible name, despite being a good drug. Of course, it should have been named trihexyphenidyl trope. That would have helped a lot, but it wasn't. And you also have the drug oxybutinin. That's a drug that we need to focus on as well. So a couple are harder to remember. The good news about this table, most of the drugs here are going to be covered in later lectures. They're important in various clinical situations, and we will discuss those at a later time. Atropine, as we've discussed, can be very important in the management of acetylcholinesterase inhibitor overdose. Tropicamide, good for dilated eye exams. It has a much shorter duration of action compared to atropine. In fact, atropine in the eye can last up to 3 days, but tropicamide only lasts a matter of a few hours, so more likely to use tropicamide for a dilated eye exam. Ipratropium and tiotropium will be covered later on when we talk about asthma and COPD. Scopolamine will be covered later on in a section that looks at antiemetic drugs. This drug is useful in motion sickness. Benztropine and trihexyphenidyl will be discussed in our section on Parkinson's disease. Again, blocking muscarinic receptors can be beneficial in that condition. Take a look at oxybutinin. This is a drug that's a muscarinic blocker used in overactive bladder, also known as urge incontinence. The exam loves patients who urinate too much or who can't urinate. The person with urinary incontinence, you need to stop that urination by blocking muscarinic receptors, and this drug would be very effective for that. On the other hand, the patient who experiences a non-obstructive urine retention can benefit from bethanechol. Our next group of drugs are nicotinic receptor antagonists, and it includes our ganglion blockers. The drugs are hexamethonium and mecamylamine. The reason to know these drugs for the exam is not because of their clinical use, because they're really no longer used clinically. They're important because they prevent reflexes. They prevent that baroreceptor reflex-mediated change in the heart rate. This slide and this margin note reminds us about our bridge to physiology related to autonomic dominance. As we discussed earlier, parasympathetics are going to dominate dually innervated organs, whereas sympathetics dominate those organs only innervated by this pathway. That would be sweat glands and blood vessels. So from knowing this, you should be able to predict the properties of ganglion blockers, which we're going to see in the next slide. If you look at the different organs listed here, and you remember that the system as it's described is actually the dominant system on that organ, here's how you can predict the properties of a ganglion blocker. For example, most of these organs are dually innervated. The heart, the eyes, the GI tract, the urinary tract, salivary glands, those all have dual innervation. So parasympathetics are going to be the dominant system. But blood vessels, that would include arterioles and veins, and sweat glands are dominated by the sympathetic nervous system because, once again, they're the only system that innervates those organs. How do I fill out the right side of this table? You can predict what a ganglion blocker is going to do if you remember this rule. Ganglion blockers give you the opposite of the dominant system. Let's look at some examples. When it comes to the heart, we know that parasympathetics dominate the heart. So what's the opposite of the parasympathetic effect on the heart? The opposite would be tachycardia, because parasympathetics would cause bradycardia. What about pupil diameter? Parasympathetics should constrict the pupil. Ganglion blockers cause the opposite, which is mydriasis. What about some organs that are dominated by sympathetics? When it comes to blood vessels, it's innervation at alpha 1 by sympathetic pathways that are the most important part there. Alpha 1's vasoconstrict. So what does a ganglion blocker do to blood vessels? The opposite, which is vasodilate. Notice, sympathetics dominate sweat glands, causing sweating. Ganglion blockers cause anhidrosis. This cartoon can be very, very helpful as you solve some of those cardiovascular trace problems. Remember the ones where you're asked to identify who is drug X. Here's why I like this picture. It shows you the blood vessel, it shows the heart, and then it shows the components of the autonomic nervous system. It makes it very easy for you to place drugs directly on this diagram. This is how you want to consider those ganglion blockers and their role in helping you to identify certain drugs. Let's give a couple of examples looking at this picture. What if you gave somebody an alpha-1 agonist? Well, we know that alpha-1 agonists are important vasoconstrictors. You vasoconstrict, you increase TPR, you increase blood pressure. Now what happens next? The baroreceptors are going to sense the increase in pressure. They're going to tell the CNS that we need an autonomic response. Since the pressure is high, the pressure is increased, we're going to get an increase in parasympathetic firing to the heart. That's going to lead to a reflex bradycardia, firing those parasympathetics through the ganglia on the way to the heart and M2 receptors. On the other hand, if you gave somebody a vasodilator, like a beta-2 agonist, beta-2 agonist would vasodilate, decrease TPR and blood pressure, and that would cause a reflex tachycardia by firing sympathetic pathways to the heart, stimulating beta-1 receptors. So what would pretreatment do to either of those two types of drugs we just discussed? If I pretreated with a ganglion blocker, now place that drug on this diagram. Go to the ganglia, draw an X. That's where the ganglion blockers are going to work. Now, I give an alpha-1 agonist in the presence of a ganglion blocker. What happens? The blood pressure still goes up, but the heart rate stays normal. Right? The ganglion blocker does not stop the binding to the alpha-1 receptor. What it stops is it stops the system from sensing that increase in blood pressure and causing an autonomic response at the heart. Similar, beta-2 agonist vasodilates, would normally cause a reflex tachycardia, but in the presence of the ganglion blocker, there will be no effect on the heart. It's a way for you to identify, does the drug in question work directly on the heart, or does it change the heart rate due to a reflex? Now see if you can solve this problem. A patient was given an unknown drug. The blood pressure went down and the heart rate went up. That's the first part of our experiment. In the second part, we pretreat with a ganglion blocker. What we observe is that the blood pressure goes down and the heart rate still goes up. Now you tell me, what receptors is that drug likely working on? The blood pressure went down, so we would suspect vasodilation, perhaps through beta-2s. But here's the important part. The heart rate still went up even in the presence of a ganglion blocker. Since the ganglion blocker had no effect, that means it was not a reflex tachycardia. It had to be a direct effect of this drug, which means that drug works on beta-1s. That drug in my example was a beta-1, beta-2 agonist, perhaps a drug like isoproterenol. So you should be able to see how useful this figure could be as you solve problems. Make a note to yourself. Refer to this picture when I do those types of problems. Now that we've completed this chapter, let's do some practice questions. Here's the first one. Once again, pause the video, solve the problem, and then I will discuss. A typically effective dose of atropine is given to a patient poisoned by malathion. You know, let's stop right there. Let me give you this strategy for reading questions like this. Every time you come across a drug in a question, I would ask that you stop and classify that drug, because studying drugs by class makes the most sense. Here's how I would read this question. A typically effective dose of atropine. Stop. Atropine is a muscarinic antagonist. Now keep going. It's given to a patient poisoned by malathion. Let's describe that drug. Malathion is an acetylcholinesterase inhibitor. In fact, it's an irreversible acetylcholinesterase inhibitor. It's an organophosphate insecticide. The question goes on to ask us, Which structure below will continue to be overactivated even after atropine is administered? But if you think about it, atropine is a muscarinic blocker, and malathion is a drug that's going to increase the levels of acetylcholine. With more acetylcholine, I can activate both muscarinic receptors and nicotinic receptors. What this question is really getting at is if atropine stops the muscarinic effects, it has no influence on nicotinic effects. So which answer choice here is consistent with activating a receptor that is nicotinic? And that, of course, would be choice D, skeletal muscle, N sub M receptors. Here's question number 2. Once again, pause the video, review the question, and then I will review the answer with you. So a patient is overdosed with atropine, once again muscarinic antagonist. Mistakenly, pyridostigmine, an acetylcholinesterase inhibitor, is chosen as the antidote. This was a bad choice because pyridostigmine can't reverse the effects of atropine where? This is more of a question about the kinetics of pyridostigmine. You remember that pyridostigmine, like neostigmine, is a quaternary amine. It's very water-soluble. It doesn't get into the CNS. Choice E is the correct answer. And here's question number 3. Pause the video, take your time on this question, and then I'll review the answer. A 35-year-old woman has a 1-month history of intermittent ptosis and diplopia. She has limited abduction and elevation of the right eye, fatigable ptosis of the left. After 2 days of pyridostigmine, her ocular symptoms resolve. If you stop right there, did you have any trouble identifying the condition? No, this is myasthenia. The symptoms match and the treatment matches with pyridostigmine. 1 week later, she develops nausea, abdominal cramping, and some diarrhea, most severe 30 minutes after taking pyridostigmine. We want to know what medication can relieve her GI symptoms. Well, isn't it a fair question to say what receptor is causing those GI effects? If you think about it that way, nausea, abdominal cramping, and diarrhea all come from overactivation of muscarinic receptors. That should make this question even easier for you, because the question now says, how do I stop muscarinic receptor activation? And you should come up with muscarinic antagonist, and the prototype there is the drug atropine. There is another question that you should answer right now, though. Perhaps you're thinking about this. If I give this person atropine, is this drug going to interfere with her myasthenia therapy? Think about it, because the answer is no. The reason why a muscarinic blocker doesn't interfere with pyridostigmine's treatment of her myasthenia is a condition that involves antibodies to nicotinic receptors. Those are N sub M receptors at the neuromuscular junction. Muscarinic blockers have no influence on that. So atropine can relieve the side effects. Most often those are muscarinic mediated side effects, but not affect the nicotinic receptors.